Hello there, I'm here to talk to you about neuroprognostication. It's a very brief overview, and we'll talk about the crucial decisions by whom, the difference between prognosis and prognostication, and some research updates. What I will not focus on, because we just don't have the time, is the various diseases and how we could differentiate prognostication. It would be too ambitious to teach you how to prognosticate for each disease that we see. This is more of a general overview. Just some terms right off the bat. If I talk about SABI, severe acute brain injury, I mean TBI, ischemic stroke, and hemorrhagic stroke, the three most common diseases we see. Subarachnoid hemorrhage and cardiac arrest are certainly other diseases we treat as well, and there is a lot of data on those diseases as well. It just will not fit all into this talk today. And when I talk about goals of care, what I really mean is the decision around continuation or withdrawal of life-sustaining treatments, including everything around it, so that might be post-ICU care and where patients go, the need for trach and PEG, and much more. So why is this so important? It's because our patients cannot make decisions on their own. Families must assume the surrogate role and make these difficult decisions. Our patients are too ill, they're incapacitated, sedated, sometimes comatose, and the brain injury leaves them without decision-making capacity for weeks, sometimes longer, sometimes for life. And as patients survive the first week, as you all know, families will ask, what's next? What's the prognosis? We will think about trach and feeding tube, and of course discharging them to the next level of care, and sometimes we have to bring up comfort care. The key to this decision-making are really patient values and preferences, as well as the prognosis. The decision-making in SABI involves two main groups: the clinical team, so that's the physician, nurses, and the reason we have to make decisions is we have to triage who and what to mobilize, what to do, what procedures to offer, and also how to communicate with the family. And the decisions involving the family really include taking on the surrogate decision-making role, the decision about continuation or withholding or withdrawing ICU care, what the patient would want, and whether they make the right decision for the patients. And often there are financial decisions to be made as well. Ideally, clinicians should combine the evidence and preference-based medicine when advising families. The evidence, including the prognosis as best as we can come up with it, some intervention effects, the patient preferences, such as personal values, maybe an advanced directive, and then the expertise of the clinician and bringing it all together, the synthesis. However, often that's a balancing act and much easier said than done, and actually rarely achieved. There's an important difference between prognosis and prognostication. Prognosis comes from the Greek word pro, before, and gnosis, knowing, so knowing beforehand. And as you know, we just don't know beforehand what will happen for sure. All we can do is prognosticate, foretelling the future from signs and symptoms using probabilities. Also from the Greek, from the word pro and gnosticate, to foretell signs and symptoms, to foreshadow, to predict. Prognosis indicates knowledge, and it's very rare that we know for sure. In reality, we use prognostication that indicates probabilities, the likelihood of a certain outcome. We have to really acknowledge that unless a patient is brain dead, all we can do is prognosticate, provide a probability of an outcome. We know from our research that families want you to be as precise as possible so they can make informed decisions. But if you're not certain, and we're never certain, they want you to acknowledge that uncertainty very clearly. Here's an example of a patient with ICH who's 87 years old and the 12-month outcome based on some variables. On the left-hand side, you see an icon array. So these are the probabilities of either death or moderate to severe disability or mild disability based on a validated prediction model. We have to be very careful using such prediction models because there's a lot of uncertainty around this. For example, we don't know whether the patient will end up in the black, blue, or gray category, and we have to be very clear on that. There are no guidelines and no standardized approaches to prognostication, And I'm sure you've seen a lot of variability, and that makes it very, very hard. There's a small paper by a colleague at Yale that showed how many factors clinicians might consider when they're prognosticating intracerebral hemorrhage outcomes. There's the ICU complications, maybe a prognostic model, comorbid conditions, whether someone has early DNI, DNR, and the provider hunch and experience, and a bunch of other things. I will say that I'm the co-chair of a guideline that's in the works. It's an international guideline between the Neurocritical Care Society and the German Neurointensive Medicine Society about neuroprognostication in 8 diseases, and we hope to have that project finished after 4 years with publication in early 2023. So stay tuned on that. Many consider the neuroprognostication an art. So there were papers in 2010 that mentioned this, and again in 2020, and really nothing has changed in over a decade. But I'm here to challenge that. Should it be an art? An art to me means it's really open to interpretation and anyone can think and do whatever they want. I strongly believe that we should try to ground people and at least try to partially standardize the approach. Here's an example in traumatic brain injury, a landmark paper published in 2011 in Canada where 6 level 1 trauma centers were selected to randomly pick 120 patients and look at how many of those patients died from withdrawal of care. And even after adjusting for known predictors of mortality, such as Glasgow Coma Scale, pupillary reactivity, sex, age of the patient, there's still a huge variability of dying from withdrawal of care depending on the center. So in some centers, you had less than half the odds of dying from withdrawal of care, and in some centers more than double. And that really shows that there's a huge variability. And additional research has been done that shows that some of that variability might be explained by location and patient race and religiosity, but really not all of it. The same holds true for cardiac arrest. So you can see the same thing here, the adjustment of good outcome based on the center and other predictors. And again, seen is this very large variability. And a similar paper has shown this in ICH. So it really exists throughout all the diseases. So if we don't have guidelines and we have a lot of uncertainty, how should we prognosticate? So right now it's expert opinion only. We do have guidelines that mention only what not to do, and it's really unclear how to train clinicians how to communicate and come up with a prognosis. So the expert opinion that we have is that shared decision-making should be employed. There's a statement that was published in 2016 by the American College of Critical Care Medicine and the American Thoracic Society. And there's also guidelines that say what not to do. So here's a practice guideline on disorders of consciousness that were published in Neurology in 2021 that really says when discussing prognosis with caregivers of patients with a disorder of consciousness, meaning coma, during the first 28 days post-injuries, statements that suggest that patients have a universally poor prognosis should be avoided. However, what we really do in reality is not always what families want, and we've shown that in a qualitative study where we talked to prior surrogate decision makers and physicians of patients with moderate to severe TBI. And the surrogates preferred exact numeric estimates in the majority of cases, and very few surrogates wanted qualitative predictions such as highly likely or unlikely, but that's exactly what physicians do because of the uncertainty. So the majority of physicians state that they typically omit numeric predictions for 2 reasons. First, they don't trust the accuracy of existing TBI models, which is the only way to come up with these predictions. And also they want to avoid creating false hope. However, that also brings in bias by the physicians. So what we showed is that the family needs is not what physicians practice. We also asked physicians what they think about models that can give you a numeric prediction. And as I said, there's mistrust in the data. People also believe that these models are not for individuals, but meant for research. However, some physicians did think that they're helpful in at least reducing the noise, reducing physician variability in a heterogeneous disease but then some others felt that statistical models and numbers may mislead families. So experts, as I said, recommend shared decision-making when discussing prognosis and goals of care. So let's dive into what that is. It's essentially a collaboration between the physician and the family. The physician provides the information on illness, prognosis, and treatment options. The family provides information on patient values and preferences. And then together, using the best scientific evidence and the provider's expert knowledge and the patient values and preferences, hopefully through a collaborative process, there is a joint deliberation about quality of life, treatment options, and goals of care. Hopefully families are then fully informed about all care options and then can make a goals of care decision that are the best individualized decision for that specific patient. Sometimes people wonder if patient and families are really up to it, and we've shown that the majority, yes, 85% of families do want to engage in that. So what we've done, because none of such tools exist that can facilitate shared decision-making, in the last 5 to 8 years, we've designed, optimized, and tested a shared decision-making intervention. It's also called a decision aid. We first started off with creating a paper tool that was part of a grant. And in the end, as you know, we did a feasibility trial at 2 centers, UMass and Yale, and that's now been published as of this year. And we were able to show that it's feasible to deploy such a tool, but whether it's effective in doing anything, well, that is a larger grant that's still yet to be funded that can show us that. But what we were able to show is that 82% felt that this tool is good or excellent, and actually 96% felt that the decision aid was useful when making a decision about goals of care in their family member. In the meantime, we've received additional funding to create a digital decision aid, and we're in the middle of that. So it's no longer pending. We do have the funding, and we're in the middle of optimizing that and doing some eye tracking. And then the hope would be to repeat a feasibility study with a digital tool. As you know, we're also audio recording family meetings, and what we're doing with that, often combining it with recordings from other centers. We're looking at how clinicians disclose prognosis and a prognostication to families. So we're doing multiple analyses on this. Here's one paper that a medical student has published. We analyzed a total of 43 audio recorded family meetings. And we showed that in 44%, the clinician never asked about patient values and preferences, which, as you know, is one of the key features about shared decision-making. We also showed that there might be a difference. This is very small numbers, but there might be a difference in how the prognostication was done and how the communication was done, depending on whether a neurointensivist was involved versus a non-neurointensivist was involved. But again, this is very preliminary and early data. So we're continuing to collect audio recorded family meetings. We're looking for your help to identify them so that our research team can go and consent the family. So in summary, I showed you the current state that we need to understand more about how we currently prognosticate and communicate. There needs to be guidelines to standardize that, but to do it well, we're very far from that. There are some interventions in development in the neuro-ICU. I do a lot of that work. There's also others working on communication training. And the final goal at some point will be to change practice, to have a less variable approach, a less anecdotal approach based on the physician's individual experience, and using a bit more evidence-based and shared decision-making. Thank you very much. Feel free to contact me if you have additional questions.